You're still a student. You're paying for life. Go get the free food.
So let's go ahead.
That we could put on the web, right?
Oh,
hey,
yeah.
Neil. Seeing you tomorrow. Right?
Hello, everyone. I think we'll go ahead and start. Welcome to our IDL talk today. Most of you know who I am, but for those who don't, I'll just very quickly introduce myself. My name is Vishnu Mohan. I'm an assistant professor in the Department of Medical Informatics and Clinical Epidemiology. Try saying that 3 times after 4 beers. And I'm an internist, but a few years ago I had an epiphany and became an informatician, which signified a mutation and a change in the way that I think. I'm particularly interested in how physicians interact with technology and how technology either helps or hinders physicians make the kind of decisions they need to make. One thing that I will add is that I'm also a DMICE alum. So I have a certificate and an MBI from DMICE, and they can't get rid of me, so now I'm still here. I'd also like to introduce, so it is my privilege to introduce today to you Jeffrey Gold. He is an associate professor in the Division of Pulmonary Critical Care in the Department of Medicine here at OHSU. He's also the program director for the Pulmonary Critical Care as well as the Critical Care Fellowships. He is a co-director of the simulation effort here at OHSU. He's also involved in medical student curriculum development and wears a lot of hats. But none today, it seems. At the onset of this talk, I would also like to welcome all those people, all 3 of you who are in cyberspace. Hello, welcome. And there is a Twitter way to get in touch with us so that you can ask your questions, and that Twitter handle is?
OHSU Informatics.
Easy enough. We'd like this to be a very informal talk, and we would also like it to be an interactive talk. Most lectures end up with people presenting slides on PowerPoint, and PowerPoint has bullets, and bullets can kill you. So what we would like to do is to start a dialogue. Please feel free to interrupt us, ask questions. We enjoy that. This is literally a dog and pony show, and you guys are all part of the circus.
I'm not sure which I am, actually.
I'm not going to go there. Oh, and we said we'd start with a slide that really represents what we've been thinking about for the last week very seriously. We both have theories. Most of it has happened. I think he's a Hydra agent. I really want to start this talk by placing us in the right context, that electronic health record adoption has been, well, placing us in the right context with my co-presenter falling down. Electronic health record adoptions rates have been very strange. If you think about the history of EHRs, they've been around for decades. The first EHRs were out in the early 70s, and an adoption rate was staggeringly abysmal until a few years ago when meaningful use came on board and changed everything. And now, all of a sudden, in just a few years, we've gone from EHR still being a niche product to some degree in many hospitals to being a universal product in most hospitals.
And you know, to sort of finish that statement, from me as the clinician side of things, who's my background being in patient safety and healthcare administration, I was the director of all the critical care units at Bellevue Hospital in New York, was involved in implementation of multiple EHRs. I will say right now that the electronic health record is the only medical device used by every single provider in a healthcare system. Right? There's no other thing. You know, not everyone puts in IVs, not everyone does central lines, not everyone does robotic surgery. But everybody, from an administrator to a nurse, to a respiratory therapist, to a clinician, to a PA, to an NP, to billing people, everyone interacts with the EHR, and the EHR becomes the central repository for all information. And that information is what is used by everybody for clinical decision making. It's used for reporting on meaningful use for patient safety, right? You know, when you look and see how OHSU compares, we're a top 10 hospital. We're a top 10 hospital. Why? Because we kill less people. Well, how do we know we kill less people? Because we extract our data out of the EHR, and the EHR said we killed less people. All of that data it's at the nexus of every single aspect of healthcare delivery today. So not only is it just the adoption, but it's universal in its impact and its use.
It really goes back, I think, to what Joan Ash is here today, and what Joan said many years ago about the EHR. See, I just said Joan Ash is here just as she was like, and Joan first kind of articulated this really well, that the EHR is the center of the universe of clinical care, that there is actually an artifact now, an idol around which everyone in the healthcare system congregates and uses as a fount for information. That's never happened before. It's always been, not only is the data fragmented and hard to get at, but there is no single object that is venerated as equally by all disciplines within the clinical environment as the EHR has been. And so, I mean, some hard data to back this up. We know that hospital adoption rates of EHR have jumped from just about 12% in 2009 to over 40% in 2012. And again, this jump occurred more towards 2012 than it did towards 2009. That 85% of all hospitals report meeting some or all objectives of meaningful use. That 54% of all physicians were using an EHR in 2011, and the number is much higher now. And again, what I want to emphasize is that this is a train that is rolling down the mountain at an extraordinarily fast speed. It started slow, but it's not gathering very much moss. It is really, really taking off in the United States in a way that has never happened before.
And I'll just, if I had to give you guys by a show of hands, as you know, not only is this train taking off, have you guys lived in New York City? Anyone lived in New York? Okay. So what's one of the things, if you do public transit in New York City, that you wish you had? Wi-Fi. No, public transportation. What's the biggest problem?
She's a Portlander now.
Okay, so Wi-Fi and public transit. But what's one of the big issues with the subway system in New York, besides that it smells and it's hot? All the trains go which direction? North-south, right? Very few crosstown trains, right? You wish you could have more crosstown trains. Do you know why you don't have crosstown trains? Infrastructure. What about the infrastructure? Well, no. So here's the issue. In the very beginning part of the 20th century, there were multiple different companies that owned the subway lines. So the 456 line, which is the IRT, as well as I think the N and the R, were owned by one company. The numbered lines were owned by a different company. Those subway tunnels are different sizes, and the trains are different sizes. So you can't connect them across. So now, think about it today. So show of hands, if you think there's less than 20 EHR vendors, raise your hand. Less than 60. About less than 100. About less than 200. Less than 300. So right now, not only is this train taken off, but we have 350 different subway lines in use in the United States, none of which can have the trains go across one another. So again, when we talk about the problems associated with this train has left the station, imagine now there's 350 different train lines, each one slightly different tunnel, right? Because in order for the subway train to be efficient, it has to match the tunnel exactly. Otherwise, you get a big wind blast and people fall in, and the train rattles and hits the walls and stuff like that. It rattles anyways, but it doesn't hit the wall. So that's one of the huge barriers, right? So when we're going to be talking about in a minute is that, well, how do you even use this system effectively? How could you determine an optimal way to interact with this piece of technology? You have 350 versions at least in use in this country alone, and there's no standardization on how to make them. There are some standardized codes, right? HL7, things for medication reconciliation, but there's nothing that says that an interface has to have these qualities. So now imagine 350 different subway trains. Some can have sliding doors. Some you buy your ticket on the train. Some you buy it upstairs. Some uses a card. Some use a token. Some have straps. Some have seats. And absolutely, some go vertically. Some go on slants. no standardization whatsoever. So just to put into perspective what kind of problem that we have to try to solve now. This is the mess we've gotten ourselves into. New York is still paying for it just for 2 subway company lines. We still can't get a freaking crosstown subway in New York.
But the problem with healthcare is that patients are going crosstown all the time, right? And they're taking train after train and system after system, and there's a perception, rightfully so, that the trains are not taking patients where they want to go. So if you want to get from, the east side of Manhattan to the west side of Manhattan, it's probably quicker to walk than to take a subway. So what we want to do in healthcare is not only develop train lines that that work across town, but if we can't do it, we need to develop a taxi service that can ferry people across town efficiently so that they can get from one train line to another. And this segment of this talk was sponsored by New York Transportation.
No, it's the MTA. The MTA.
What do I get? So I put this slide up because we want to kind of focus on patient safety and errors that creep into medicine. And I will tell you, I've been practicing medicine for some time now. And I've seen things you people wouldn't believe. I've attacked ships on fire off the shoulder of Orion. I've seen C-beams. All right. So, time for me to leave now. When I started as an attending, they wanted me to pick a committee to serve on, and I picked the Patient Care and Safety Committee in my hospital because it only met 3 times a year. And then I thought I was a very good choice. And then Pennsylvania passed the MCARE Act, which required all errors, critical misses, and significant patient errors to be reported into a patient safety database. And we went from meeting 3 times a year to meeting 3 times a month. And then broke up into subcommittees so that we could meet more often because we were identifying so many errors in the system. And I think we're at a stage of history now where we think that the solution to errors that occur because of healthcare, and believe me, there are plenty of them, we think the solution is to implement a layer of technology that will help us to reduce the errors. But then the unintended consequence of that is that the technology itself is responsible for different kinds of errors, and we think the solution to that is to implement another layer of technology on top of it that will help to identify and suppress those errors, and this story goes on.
And so, to give you an example of the way I got into this research is, full disclosure, I am a basic scientist. All right, so I played with cell cultures for a long time. I know how to grow macrophages. I know how to grow neutrophils. I play with mice. The mice play with us. They're fun little creatures. It was the 4-legged mice, not the mouse clicks I used to deal with. I started back at Bellevue, and I used to believe that every single person who has a cardiac arrest in an ICU, that it could be prevented. That you should know when something bad is going to happen because you have all the data in the world. You have real-time reporting of all your blood pressures, all your labs. And so I would review each one that would happen because that was my job. I was the director. And what I would find is that for hours, you would see the clinical decompensation of the patient happening, and it would be completely unrecognized. Now, if you want to say, is this unique to maybe we just had bad doctors at Bellevue? Well, there was a study out of Australia that showed that up to 36 hours prior to cardiac arrest on the floor, there's evidence of clinical decompensation. More than half the time is it missed, and when it's recognized, less than half the time is it acted upon. So alert fatigue in many respects, that they say there's a problem and they still ignored it. When I started off here, we'll show a little bit of our research in a bit, but when we went live with Epic, one of the things that I did, we had our weekly M&M for our division. Every week, we do M&M, morbidity and mortality. It's where you review errors or deaths in your clinical environment. And my fellows said, we don't have anybody. Like, a whole week you guys have been here and you didn't do anything wrong? It's like a miracle. It's like your kid actually cleaning your room every day. And they said, no, we didn't do anything wrong, no problem. So I said, okay, give me the most complex patient in the ICU. Somebody who's been there for a while, on a ventilator, on a lot of medications for their blood pressures, and let's pull up Epic. And again, this case, Epic being our in-house EHR. And what we did is found about 15 to 18 different errors that were completely unrecognized by the team. Best practices not being adhered to. They didn't realize. Dangerous settings on ventilators. They didn't realize. Stuff that was being charted by the nurses that because they didn't pick up on it, they didn't realize. Errors go both ways. I was on rounds one time. Resident is presenting to me. It says, you know, Mr. So-and-so, blood pressure was this. Oxygen saturations were 92 to 98%. And you keep on going. And you're listening. You're like, okay, that sounds great. 92 to 98 being quote-unquote normal numbers. Okay. I'm looking at Epic in real time. No numbers have been charted for the last 18 hours. Nothing's charted. They pulled the data in from the electronic health record, and it gave the most recent data, which was in that nice range, but nothing charted. No one realized that. The nurse didn't realize that nothing was being charted, even though they were responsible for the charting. And the doctor didn't realize it. So again, all of these unintended consequences. The last thing I'll say really quickly before we move on to the next slide. For those of you who read the New England Journal of Medicine, about 2 weeks ago, there was a very famous article. There was a landmark article that came out about the use of surgical checklists. This is one of the issues. As we've tried to move towards making things safer and moving things electronic, the checklist / bullet point has become an end unto itself, right? Pull up something, check the, how do you know you did it? You check the box. And of course, we all do this all the time when we download and update our iTunes, right? We read the terms and services of agreement, and we check the box. And I guarantee you none of you have actually read that entire thing. So what did they do? They had this nice survey, this checklist that had been shown to improve surgical outcomes in multiple small studies. And then they implemented it across the entire province of Ontario. And I've been to Ontario. They're very nice people. I don't think that they're the reason that this study failed. And what did they show? Absolutely zero impact on clinical outcome. Zero. Zero. And again, what it shows is that when we try to make the process an end unto itself, the unintended consequence is that you lose sight of what your meaningful outcomes are. And that's how we get to these unintended consequences. We focus so much on the process that we lose track of seeing, does it actually impact outcome?
And part of the reasons is because outcomes are just so hard to measure, right? I mean, outcomes in clinical studies are much easier to measure than outcomes in informatics studies and clinical informatics studies because the parameters are different and the way that we can show cause and effect is to a considerable degree different. I think the moral of the story really is that healthcare isn't safe. I mean,
but it's delicious.
This is a video game called Surgeon Simulator where you are a surgeon, you have to operate on people, but your hands shake like crazy. And you have tools like hacksaws to take people to do ophthalmologic surgery. And you end up killing patients a lot in this video game. But real life is something like this. In a video game, it's funny. In reality, it's not. Jeff mentioned all these issues that he would face in the ICU. I'm predominantly an outpatient physician, and every one of Jeff's points resonate with me. When I precept residents, we have the same kind of issues that Jeff does. It's just that our timescales in the outpatient world are very expanded compared to the timescales in Jeff's universe. Our problem is that we both deal with Swiss cheese. The outpatient problem is there's more holes than cheese. The inpatient problems is that the holes are all in the wrong place.
Right.
The other issue is, I think that's really interesting or maybe important, is that when you are talking about outpatient, inpatient universes, what you're really talking about is a fundamental inability for physicians to do what they do. And the reason that exists is because I think we don't understand fully how physicians interact with the system in order to get the information that they need yet. And that's something that Jeff and I are trying to figure out in our research, how this process actually occurs. We know that physicians are expected to engage in vast amounts of analytical thinking where they function like Sherlock Holmes looking for clues and finding pieces of information that help them to build a case layer by layer, brick by brick. It doesn't happen that way. What we do most of the time is look for patterns. And if we can't find specific data in the electronic health record, we can't make those patterns. And if we can't make those patterns, we can't make the diagnosis. And so an electronic health record that is safe and allows physicians to diagnose and treat diseases should necessarily allow those patterns to be recognized. Well, one of the things that I always thought, one of the reasons I became an informatician, is that my primary hypothesis was that EHRs would help improve healthcare delivery. I mean, there does seem to be evidence that suggests this, right? We know that EHRs increase efficiency of information storage and retrieval. We know that they improve healthcare quality. There's multiple studies that have examined this in their own ways, most of which are flawed. And we know that EHRs improve coordination in care of diseases. I mean, this is really an efficient way to use electronic health records as opposed to paper health records. We know that EHRs allow clinicians to deliver better care, although the definition of better care has an almost Clinton-esque connotation to it. And we know that CPOE reduces...
I did not have.
I'm not going to go there anymore. So we know that CPOE reduces medication errors and specifically reduces adverse drug events. So there is a body of literature that is growing over the last 20 or 30 years that suggests that EHRs do have a role to improve healthcare delivery. But as you'll see in the next slide, the converse can also be argued.
Right. And actually, just go to the next slide, and I think that'll make it more apparent. So what we also know, though, is that multiple studies have seemed to show that the EHR can also have negative impacts on patient safety. And a lot of these seem to occur to be directly related to the amount of data that are required for you to get through. Meaning that specifically in ICUs of where a lot of these bad outcomes have been shown. So for example, Han's study, which showed at University of Pittsburgh, right, they implemented an EHR, and there, just due to poor implementation, they saw a dramatic increase in mortality. Why? Because they couldn't put in the orders for the kids before the kids got to the ward, because you can't put in orders on a patient unless the patient is actually active in the system. They can't be active in the system until they're present there. Huge mess. Still, by the way, if you go to our ICU today, if a patient goes off the floor to a dialysis, they're actually temporarily discharged out of the ICU, and they're not actually on the ICU patient list, if you're to look at the unit census. So this problem still happens in some ways or another. And a lot of these are due to deficiencies in cognition and problems with association of recognition of data. Meaning, can you see the forest through the trees? The example I would give you, if any of us ever gets the ability to go to Mars, right? The big mountain on Mars that's about 36 miles high. There, the mountain is so big and the slopes are so gentle, you never know that you're on a mountain, because it looks like you're walking on flat ground, because the slopes is so big. That's sometimes what it's like looking at the data. Can you see the trend in the data when you're in the middle of the trend? If any of you are bike riders, it's the same thing when you're on a gentle grade going uphill and the road is straight and you have no perspective. All right? And this is made worse by the fact that you have alert fatigue. So alert fatigue is something that was coined and termed from the clinical monitor environment. So you go to any clinical environment, every time you get an abnormal blood pressure or heart rate, everything else, something will beep at you. It's the machine that goes ping. We always have the machine that goes ping. The problem is that in our EHR, because normality is determined by population as opposed to by individual, everything becomes an alert. So you could have 40 to 50 lab alerts a day for a single patient in an ICU, for example, all of which are completely normal for that patient. How many of you have been told, a lot of you have probably been told you're slightly anemic, all right? And that is your normal baseline hematocrit. Yet in the EHR, a little red arrow will go right next to it. So now what do you do if you're a clinician? You say, I know Jeff. He's slightly anemic. He's had a bunch of surgeries in the past. It's normal for him. So what do? You start to ignore that alert. Now what happens if it drops a little bit more? Now I'm having some bleeding. I still have the same red arrow. Now I have to all of a sudden pay attention to that red arrow. Or what's even worse is like what we had in the ICU just 2 weeks ago, someone who came in profoundly dehydrated. So now the red arrow goes away because they've concentrated all their blood cells. The abnormality was the fact that they've returned to normal. So being able to customize for each individual patient is what the goal should be. But again, it's almost impossible to do that with today's current systems because of reporting structure. And what I will tell you just as a last thing is there have been a couple studies that have come out that have shown, for example, in Colorado, when they looked at private ambulatory practices that adopted EHR, no impact whatsoever on med-mal claims. So while not necessarily a surrogate for patient safety, you would think that would be one of the benefits, right? Is that better documentation, improve, maybe reduce money spent on med-mal? No. There was an article that came out about a year ago that showed that providers who had access to radiographic studies in their office were actually more likely to order more. And actually radiographic test ordering went up. So actually increasing cost. So again, many unintended consequences, not just related to patient safety.
So two real themes come out of this, right? One, what is normal is not necessarily normal. And because we live in a programming universe where everything has a binary value when it comes to electronic health records, it is extremely tempting to place that normal limits on a specific patient for a specific value of a laboratory test. But what might be perfectly valid in the outpatient environment is no longer valid in the inpatient environment. So these so-called normal values are not in any way indexed or linked to the situations where normalcy cannot be predicted. And the reason they're not linked is, well, can't be predicted. If they could be predicted, they would be linked. And the other issue that comes out of this is that the presentation of data is also contextual. What is important to me during this visit in the office may not be important to me a subsequent visit in the office. And so if the same data is presented the same way every time, there is no prioritization of the way that data is presented to the clinician. And this leads to serious cognitive effects because we are bombarded by alerts that are irrelevant. And therefore, if one person cries wolf, we may pay attention. But if the entire room is filled with wolves, then it is impossible to predict which one is actually crying wolf.
And so, go ahead. And so then you got to figure out, well, how the hell am I going to solve this? Right? How are we going to get at this? Because now you have 3 degrees of freedom. You have 350 different subway trains, different EHR vendors. You have 50 different provider types in a given hospital system, if not more, inpatient, outpatient, level of training, level of provider, administrative, clinical, and every case is different. Right? Every patient is different. So you have 3 degrees of freedom, all of which pivoting, and then we're supposed to be able to understand how best to use the system by just observation. And that's where our research has been focused.
So the moral of this story really is that the initial assumption we had was that it was all because of the EHR. I still attend grand rounds or clinical meetings where we discuss, like M&M meetings, where we discuss where things went wrong with the patient. And at some point in the room, somebody blames Epic. And then everybody looks at me, right? And I think this is a very common phenomenon that we have seen in the M&M environment, where before there was a significant attempt to look at the diagnostic process and reasoning. Now there's a simple way to end the conversation. It's all Epic's fault. And when you talk to the engineers who built the system, they say, well, it's all user error. Boeing never admits, or any airplane manufacturer never admits that they are at fault right away. It's typically the fault of the pilots. And the pilots union never admits that it's the fault of the pilots. It's always the fault of the manufacturer. And the poor NTSB folks have to figure out exactly what happened in between. And it's always in the setting of a tragedy. And this typically happens in healthcare also. The patient's plane crashes. And the people who built the system blame the clinicians blame the people who built the system, and nobody wins and everybody loses. But I think once we begin to understand that the errors that can occur at multiple points, it becomes easier for us to try and focus on individual elements. Is this an issue with hardware, with software, with implementation, or with workflows? I mean, Jeff gave the example of the Hahn study, and I'm sure pretty much everyone in the room is familiar with it. But I will say that the initial assumption from that study was that it was the EHR that was killing kids. But as time went on, we went from, could it be the system, the software? We discovered it was the implementation and workflows, and we were able to reproduce some of these problems and solve them in a very reasonable way.
By the way, just so you realize, for those of you who don't keep up on the medical device literature, the National Institute of Science and Technology, NIST, their statistics will show you that for all the medical devices that are recalled, which is a sizable number, about half of them are recalled due to a poor user interface, problems with the user interface. So the idea that medical technology fails us because of the user interface, the device may be perfectly fine, but how the user interfaces with the device is the problem, is not unique to EHRs. And if anything, all we're doing is reinventing the wheel, right? We are just starting to come to the same realization now that every other medical device manufacturer has known for the last 20 or 30 years.
So if the problem is the interface, I mean, the most common question I hear, which I like, is why can't an EHR interface be like a video game interface, right? And if you look at a video game interface, I've always wanted to present Doom in a lecture, and now I have. If you look at an EHR interface, well, doesn't it give you all the information you need in a very efficient fashion? I know how much ammunition I have. I know how much armor I have. I know I don't have too much health, and if I don't believe it, I know I don't have too much health. And I know what the situation is. I know what my actions are. I know what my tasks are. I can actually predict going forward. I only have one rocket, so I'd better find that little rocket thing icon on the ground. Otherwise, I won't be able to blow up many people. Now, this seems really interesting and an obvious way to fix the problem with EHRs. Why can't we design these intuitive user interfaces? Because obviously, video game designers have been doing this since the dawn of mankind, right? I mean, Doom is not a new game. But I will point to you that this is actually a fallacy and not a solution. And the way I'll point to you is to show you a different kind of a game. Now, this is a game which is very different from the preceding one. In the preceding one, you only had small amounts of information that need to be displayed to the user at any given time. Here is a much more complicated simulation game where large amounts of information need to be processed by the person who's playing the game, hopefully me, in very small periods of time, relatively speaking. And the same problems that occur in the EHR, now you begin to see them in the video game world. This is Europa Universalis 4, the only way that I will ever have total domination of the Earth. And you can see that there's a lot of information that needs to be processed. There's shields that mean something, there are numbers that mean something. I have some sense of what the countries are, but because this is a video game, they don't make sense anymore. And the interface, the way that I can actually interact with the system is hidden in a corner. It is unintuitive. It is clunky. I never get my hands on the data that I really want to take out Aragon, which seems to be somewhere where it should not be, right? And this is...
Why is it in North Africa? I'll never know.
Because Spain has expanded.
Yes.
Because the rain in Spain falls mainly in
Aragon, yeah.
So, but when you think in terms of what is it that this system lacks, well, it lacks clarity, it lacks intuition, it lacks the ability to understand what the information represents. There's too much alerts here, isn't there? I mean, there's so much stuff that I don't understand. Well, this could be an EHR. So the solution is not necessarily to duplicate an interface from another industry, from video games or from airline cockpits or from the traditional tropes that you hear about in information discussion boards. The solution is to be more intelligent about the kind of interface that we offer clinicians. And we can't just improve an interface in order to improve quality of care and reduce patient errors. You have to improve EHR usability to reduce errors. We know this from the NIST report and also from folks like Dean Sittig. We have to, who used to be faculty here until he moved to Texas and left us. We have to incorporate usability testing into product development cycles that will reduce errors that rise because of limited information visibility, something that is obvious but hard to do. And an AMIA task force recommended improving usability of EHRs to specifically enhance patient safety and quality of care. So rather than think about improving usability as a general exercise in EHR improvement, it is possible to consider improving EHR usability from a specific focus, that of patient safety. All right. So what is the problem here? The problem is that the user cannot navigate the system efficiently. And if you've seen this movie, good. If you haven't seen this movie, please leave now. No. They go back in time. They have to save Chekhov from a head injury. And they have to access a computer. And Scott, who, as we all know, is a brilliant engineer is faced with a user interface he has never encountered before, and instead of using the mouse as it is intended, he says, "Hello, computer," and expects the computer to talk back. And here is a classic example of how, if we as clinicians don't interface with the system efficiently, we are not going to get the voice of Majel Barrett talking back to us.
And what I would say is one of the main problems is when we do our testing, the question is, we don't obviously know where checkoff is, right? So how do you know that Scotty, even if he does get Majel Barrett's voice to come back, actually found checkoff? That's the problem. So you may find that, yes, tell me where checkoff is, and you find out where he was 24 hours ago, not where he is now, because you did not query the system correctly. You may, the system may display all the places checkoff has been over the last 5 days, but because of the way the data are displayed, you read it backwards in time. So you read the stuff 5 days ago, thinking that was the most recent. So again, when all the stuff that we're talking about in terms of efficiently and safely and effectively using this system, one of our, I think the most important premise is it has to be anchored to something. You could love to use the system. You could have great usability. You could do all sorts of usability testing. You say, I love using this system. I think the interface is nice. I like the graphics are nice. If you don't do a good job of actually achieving the endpoint of the exercise you're doing, it's irrelevant. iPads are pretty. You can't, Google Maps, or not Google Maps, Apple Maps, when it came out with the iPhone 5, right? It sucked. It was still pretty. How did we know it sucked? We knew it sucked because people used that interface to get to a specific point. And when they found out they ended up in an alley in a very bad neighborhood instead of at the restaurant they went to, they said, this interface is not effective because I know where I was supposed to be. It was supposed to be at the Cheesecake Factory, and I am not there.
Even worse is if you're not using it for Cheesecake Factory, but to try and get across from Portland to the coast, and you take the wrong road because maps didn't get you there. This is Google Maps, not Apple. You could die.
Right.
And that's happened. And Jeff hasn't been long in the informatics environment to know that you never diss Apple in an informatics department.
I don't mind. I don't mind.
But I'll say this. I mean, if you look at this picture, the only clinician in this picture is McCoy, and he's standing there like a jackass in the corner because he doesn't have a clue how to use the system because, damn it, Jim, he's a physician, not a computer engineer, right? But that's how many physicians behave when it comes to using technology. They use surrogates like scribes. They use all manners of ways to get around the fact that they don't want to interact with the system because they can't do it efficiently. So efficient interaction with system is a problem because if the user cannot navigate the system efficiently, it is a given that errors will occur.
And let me put it this way. How many of you in this room have supervised a trainee at any time? Good. How many do you have in your time of supervising a trainee have had your trainee be better at using a piece of technology than you are because they learned it? Okay. Now, how many of those times when it was that you were dependent upon the data that trainee was giving you? It could be clinical data, it could be research data, or anything else. All right? So, again, think about it this way. You also have this paradigm where McCoy is now dependent upon, imagine this being Scotty being the intern who actually does know how to use the technology, or this guy who actually does, who has no clinical sense, doesn't know who checkoff is. You depend upon him to effectively gather the information, and McCoy has no way to vet that information, has no idea how, if he have got it effectively. That's the situation we're in.
So how can you improve the user? That's something that Jeff and I have kind of talked about for quite some time. And we know...
Safely.
Safely.
Right, because we could beat on them.
Right. Well, that would be the best. But I think that you have to think in terms of not just, oh, this is my solution, but what is out there that we know about improving the user that will help us. And we do have some guidelines here. The safety assurance factors for EHR resilience, safer guides, of which of which Joan was a big part, was designed to enable healthcare organizations to optimize safe EHR use in different operational areas. And the ONC has now published these safer guides. And we can see that there is a need for organizations to follow safety practices associated with specific aspects of EHR use, such as clinical decision support or CPOE, and providing the infrastructure and the expertise to allow organizations to do this seems to be a logical next step forward in improving the user. However, I think the most important piece here is if you don't train them right, they will not perform right. And so using EHRs efficiently necessitates clinicians are trained appropriately. So in order to improve the user, we have to modify the training that's given. But in order to improve the training that's given, you have to improve the system so that you're actually training them on a more efficient product. So this is from one of my favorite movies, A Bridge Too Far. My wife tells me that when we were dating, the first movie I tried to make her watch was A Bridge Too Far, and she doesn't understand why she married me.
Neither do I.
Well, I do. But in this movie, it's basically the story of how the Allies have to take a number of bridges in a very rapid period of time in order to allow a bunch of tanks to go across some major strategic points, and the story goes on in that direction. But the point I want to make is this, that there's a general who wants a bridge to be taken, and he asks Robert Redford, who plays the role of Julian Cook, how do you take a bridge? What's the best way to take a bridge? And Cook replies, both ends at once. And when we asked ourselves, what is the best way to do this, we very quickly decided that we had to build a better mouse and build a better mousetrap. And that's really the only way to do this. You improve the user by training them more appropriately, and you improve the system by improving the usability.
And then you use that training, and you use that as an iterative process to inform each side of the equation. So as you train the users, you find out there's certain things that the users will never get right because of a deficit in the system, right? One of the things that we did in our simulations that we'll talk about in a second is that could you recognize the sedation scores on a patient safety item in the ICU? Trust me on this one. What we found out is that it was buried so deep in the EHR, no one was ever looking at it because it was an area that no clinician would ever go to. So what did we do? We moved it back to a more visible area. That's where the training the mouse helped us build a better mousetrap. Conversely, when you then build your better mousetrap, you need to have a way to implement it. This falls into the realm of implementation science, so that you have to constantly incorporate that into your user education.
So the way we built that case was that the patient was over-sedated because they were receiving an excess dose of sedating drugs. And the only way you would know it is if you actually found the MAS score. And no one was actually identifying the fact that this patient was over-sedated because no one saw the MAS score, and therefore no one changed the dose of the drug, which was the appropriate action to take. And the reason they couldn't change it was because nobody taught them how to get to the MAS score, because it was buried so deep inside the EHR. It was difficult, time-consuming, and nobody really wanted to do it. So just by moving a data item to a more efficient platform, a more efficient place in the platform, and allowing clinicians the training that allows them to actually get there, solves both ends of the bridge at the same time. So we thought about doing this in real life, right? So the question is, why can't we do this in real patients? 1, because it's not safe. 2, because all patients are different. 3, because you can't replicate identical data in an ICU environment between 2 patients, even if they have the same disease, because there's just so much data and so many variables. When you're looking at over 1,000 points of data per patient per day, there's just so many permutations and combinations that the only way to standardize the experience for subjects is to do a simulation. But that simulation cannot be the same kind of simulation that you find as default in the electronic health record, because if a simulation isn't real, the subjects aren't going to have any kind of realistic experience. So there are certain specific factors of the simulation that are essential in order for it to be high fidelity.
And what I'll say about it is sort of, so Socrates said, or Plato said as Socrates' voice, right? In essence, I think it was in the Republic, that, to paraphrase, no one knows absolute truth, right? Because or no one lies, because the only way you can lie effectively is to have knowledge of absolute truth, right? Because then you can't really be lying. You have to know the absolute truth. And so the problem with using real cases is you don't know the absolute truth in those cases because there's so much data. You don't know what, you may, even if you dive in, you may not know what's going on. So what you do is you create the constructed lie where you know what is going wrong with the patient and what needs to be identified. And why is this so important? I'll go back to the Google Maps / Apple Maps, even though I will bash Apple again. You have to get to the Cheesecake Factory. But if you've been there 50 times, whether you use Google Maps, Apple Maps, or Waze, whatever it is, you will go there regardless of what the mapping function will tell you. You know the way to go there. You've been there 30 times. The key for that mapping app is whether when your 5 favorite ways of getting there are closed, can it take you through all the back roads and still get you there, right? That's the key. That's what you want in that scenario. That's the issue with cognitive and anchoring bias, and that's what we wanted to overcome as well. So it's not just a question of finding the data in the EHR. It's not a question, can you find the CRIT, can you find the CB, can you find the sedation scale, can you find the blood pressure? The question is can you recognize that data in a way to actually make an effective clinical decision? And the best way to know whether you're effective at doing this is can you recognize the unexpected? Because if all the data are congruent with the clinical information that the provider has, they're going to get it right no matter what. Right? If they're expecting that A leads to B, and the provider tells you, yep, B is what's going on, well, you have no idea if that was an effective user interface. They guessed right. They guessed right because they had momentum. They had clinical momentum. They had anchoring bias, all of which fed into it. The question is can the provider take that data and realize it's not B, it's C? And so, again, the cases that we create with a control lie, doing it on a mobile testing station identical to what we use in the ICU, and doing it in the ICU for these cases. And the way we built these cases is we put 5 days' worth of data in there so that they're actually data rich. They have all the blood pressure values for 5 days, all the laboratory values, all the nursing data for 5 days. We build in some patient safety issues that need to be recognized. And then what we do is we say, well, we want to see if real-life users could use this system. So what does that mean? 1, we give them some information in advance. We tell them what their colleagues would have told them about the patient, because that's what happens in real life. And B, or 2, or Roman numeral 2, I keep changing my bullet points, is that it's a time-limited exam. Reality is residents, doctors on the wards don't spend an hour reviewing the chart on each patient. They don't have the time. So this is a timed exam. You get 10 minutes. Review the case, tell us what's going on. And we have a set checklist to say, did you recognize these things? Did you recognize the change in the hemodynamic? Did you recognize the problem with the laboratory values? Did you recognize the fact that with those change in laboratory values and change in renal function, kidney function, that the medications are now dosed wrong? The participants are then scored on what percentage of those items that they recognize, and then are immediately debriefed. That's the purpose of simulation. The simulation is not effective because of the exercise. It's effective because of the debrief that happens afterwards, where we then go through, in the electronic health record, all the different places where they could have seen this data, how you could have graphed it, how you could have trended it better. Then what we've done is we've incorporated 2 things into this. 1, we have multiple cases. So what does that mean? Now we could take someone and have them go through it again and see, did they learn? Now, whether this was better EHR skills or better cognition because we were able to incorporate the EHR into their learning, I can't tell you yet. The second is, can we use these standardized cases in a standardized environment with lots of users within the same department to come up with, for this group, some general trends of EHR usability? What makes a good user? What makes a bad user? And we could do that by incorporating eye tracking. So this is a commercial eye tracker by Tobii Systems. And what it does is, just like you do in website design or anything else, we can see where you looked, how long you looked, and how often you looked at it. So let's see. And
I think before I get there, I think one point I'll make really quickly, and that is that it sounds evident, self-evident when you say it. You got to do it this way. It's got to be standardized patients. It's got to be high-fidelity simulation.
No one's done this.
But we had no idea when we started this whether it would actually work out. I mean, there was no guarantee that this particular simulation environment would be effective. We knew that that simulations allow the replications of clinical scenarios in a reliable and consistent fashion, not in the healthcare literature, but NTSB simulation studies on crashes allow you to reproduce the same set of scenarios in planes. We know that user errors related to poor reliabilities may be reduced by using simulations to evaluate EHRs. NIST told us this, and we have a sense of this from interesting things like automobile dashboard designs, where they have a certain switch or a certain button in a different place, and see how that affects drivability when an old lady with a carriage with twin babies is crossing the road just in front of the simulation. We know that simulations allow different usability scenarios to be tested without patient harm. That's obvious, and I think that was our driving force, because you can't keep testing these EHRs on real-life patients, especially when you are messing with the usability, because changing the infrastructure, changing the interface leads to unintended consequences, which leads to more changes in the interface, which leads to unintended consequences. And we've seen in the informatics literature that it's not the intended harm results that destroy the science. It is the unintended consequences that place such a heavy burden on the research. And simulations allow a controlled environment where human factors can be tested by using usability environments. So we came up with a fundamental hypothesis. So we felt the development of EHR simulation for the ICU would, Roman numeral 1, help identify patterns of effective and ineffective navigation of our electronic health record.
B.
2, B, improve EHR use and result in better patient safety. And gamma, provide guidance for revising and improving data presentation. Whatever. In the EHR, right? So really, if we can actually do the simulations right and develop this strategy, we identify patterns, we improve the EHR, we provide guidance for improving data, and we save the world. We picked the ICU because the ICU workflow looks something like this, right? And there's a lot of things happening in real time in a very confused and disorganized way. And for us, it's not just it's not just the information retrieval that's important. It's not the easy linear workflow that is the best use case scenario for what we're trying to prove. We want to show the effectiveness of what we're trying to do in an environment where significant complexity and significant emergent complexity exist that allow us to make a better generalization for the simple scenarios rather than trying to do this for the simple stuff and trying to expand it into this nightmare. So errors of information processing are on the rise, especially in clinical situations where large amounts of data need to be processed quickly, such as the ICU. We know that clinicians in the ICU need to process huge amounts of data rapidly, and not only do they need to process it rapidly, everything is actionable, right? That data is not that you process it in 5 minutes, but then you take 6 weeks to figure out what to do with the patient. You process it in seconds, and you have a few minutes, a window of opportunity of a very short period of time in order to make those decisions and deploy them. And the decision-making is very clearly associated with data processing skills because the lead time between the actual processing and making the decision is so short in environments like the ICU.
And just out of curiosity, how many data points do you think we need every day in the ICU? How many, if you were to look at an average ICU patient, how many data points in our EHR? Someone want to hazard a guess?
Say less than 500.
500, 1,000, 2,000, 3,000, 4,000. You know the answer to this. You be quiet, Eric. You've heard this before. So somewhere a little bit between those two. So in a study done in 2008, they showed around 1,500 data points per year, but that number was going up by 5% per year. And so I can tell you we've done it here in our system, right? We had 4,000 data points in one patient in our ICU. Now, each patient, what's an average ICU length of stay? About 4 days. So now you have 20,000 data points per patient just on that admission alone. Average ICU census is about 15. So now you could start to get an idea of the amount of data that you're actually responsible for.
So I just want to put up 2 quick pictures to give you a sense of what we've been talking about so far. First, you can see that almost every lab value in the top graphic is marked with an exclamation point. And you can see that it loses all meaning because all the hemoglobins are consistent with anemia. So that's fine. Some of the ones that are marked for that patient may not be specific for that patient, and some of them that are not marked may be important.
And what I'll show you right now is of the 3 that you would consider important, white blood cell count at the top, clinically, no difference between column 2 and column 5. A little bit of a wave, but not much, right? Hematocrit, 23, 27. That one's actually started to drift down a little bit. The platelet count, 240, 313. There's actually a 25% drop already and still continuing to go down slowly but surely. That may be the one that you have to keep your eye on the most. It's the only one that isn't alerted.
So I pointed you towards the actual flagged abnormals, hemoglobin. I mean, how many clinicians in the room actually took a look at this graph and appreciated the fact that the platelets were dropping? Probably not that many, mainly because it's so small that nobody can see it. But the point that I'm trying to make here in both these scenarios is the fact that something is marked abnormal or normal does not necessarily necessitate that it's important or not.
And for example here, right, 2 blood pressure readings, both of them marked as abnormal. One because it's too high, one because it's too low. You have no idea that the trend is actually the problem.
All right, so why eye tracking? Mainly because all my life I wanted to build a void camp machine. And if you haven't seen this movie, I also want to ask people questions like you see a turtle baking in the hot sand, but I won't go there. So I think the big reason is that typical traditional usability studies fail us because they tend to be talk aloud type of studies where clinicians are telling us what they're doing as they're thinking, and there's a huge Hawthorne effect, and the cognitive processes are mainly heuristic. It's very hard to articulate heuristic processes in any meaningful ways, and even if they could tell us, they stop doing what they're doing to tell us what they're doing. So we felt that there were many deficiencies with the traditional way of doing these studies. We picked eye tracking because eye tracking gave us the opportunity to see in real time what patients were, our subjects were seeing with respect to patient data.
So for example here, you could see this person looked at all the doses of the medications, but actually never looked to see whether this medication was actually administered, because this is the administration time. So order versus implementation. Perfect example. Here you could see the person only looked at the most recent hemodynamic values. So they have no idea that if something has changed between here and here, they never looked down here. They didn't look at the entire, they only looked at a trend for a short period of time.
And what this is tells us is a heat map. It changes color based on how long you look at a specific period of time. And so the more red it is, the longer they've actually focused on the data.
So I'm going to show you a couple pieces of data really quickly that we get out of the eye tracker. First is, as a surrogate for the talk aloud studies, as I told you, we have our simulated cases where we have these built-in errors. We have these built-in changes in patient condition. We now know where these things you could be viewed in the electronic health record. We go through every 10-minute video and score manually on each screen. Did you look at one of these safety items or did you not? We then come up with a set score of summing it all up, a density score. And what you could see is that this density score on the y-axis actually correlates pretty well with what you verbalize. So in other words, it's becoming a nice surrogate that we could actually tell, based on this density score, how likely clinicians are to actually verbalize and recognize what's going on in a clinical case. For those of you who are more clinicians out there, this correlation got much worse, actually, or got much better, I should say, when we excluded all the progress notes. So the progress notes seem to detract from your ability to actually clinically process the data.
And they do probably because there's so much junk in them. And I think it's really important for us to make sure that the measurement tool that we are using reflects what we want to measure. So one of the concerns we had is that composite score a valid measurement, a valid instrument to determine what we want to determine? And that seems to be the case.
The second thing is just for those of you who are interested in terms of efficiency, this is, now again, all these are done with our test environment in Epic. I just want to show you two things here. First of all, in 10 minutes, average person uses 20 individually unique screens to look at their data. Total of 40. And by the way, progress notes are considered one screen in toto. So if they looked at 30 progress notes, we don't count that as 30. It's just progress notes. But again, if you look at the number of unique screens viewed versus your performance on the simulation, how much you actually verbalize what's going on, there's actually a nice correlation, again, showing that people who are effectively using this EHR, now whether this is universal or not, I can't tell you, across the different vendors, seem to be scanners, seem to be able to, they know where everything is, and it's almost on autopilot. They can look, scan, scan, scan. Now, what evidence do we have for that? Is based on whether you looked hard at something or scanned it. Fixation versus a saccade. A fixation is where you look for at least 35 milliseconds or more at a data point. You would think that that means you're concentrating. Saccades are the quick scanning back and forth. And what we found, actually, is that the number of saccades actually correlates much better with performance than fixations. Going into this entire idea of saccadic decision-making, the expert users of the system are capable of scanning from one data point to the next in order to gather as much data as possible to put into their heuristic model of what's going on with the patient. Conversely, the deer in the headlights is the fixation. Not knowing what you're looking at, not knowing what's going on. What's very interesting is Jenna Marquardt, who's going to be here over the next 6 months doing a visiting professorship in a sabbatical, is doing similar work with ambulatory cases at UMass, and they're finding the exact same thing with a different EHR vendor. Suggesting, again, now we're starting to get objective markers for usability and performance, which, to our knowledge, hasn't really been done with EHRs yet at all. So that's about the limit of the day that we're going to talk about today. I know that we are already a minute or two over, so I apologize.
We could go on forever, as you probably realize, but...
So we'll leave it open to questions, and if anyone has to go, we will not feel insulted. We know it's already 12:30, and we'll stick around for a minute as well. Thank you.
Thank you. Go ahead, Brett.
We've had a couple questions come in through Twitter. So the first one is from Faiza, and she asks, is the simulation environment based on the interface design of a single specific EHR?
Correct. So
yes. So, Faiza, yeah, the answer is that what we've done is we've actually cloned our existing clinical EHR and populated it with our test cases. So the idea is that when users log in, they have their same login ID, their same user customization. It's our Bizarro world. So, but the idea is the cases are created in an Excel spreadsheet. So you could actually, if there was an actual direct interface between different EHRs, we could actually recapitulate the same case with a different EHR. And we're actually doing that with a company that we're working with now. They were here talking a little while ago named Zoetics that makes an EHR agnostic vendor. We actually have one of our cases in their system in order to be able to compare and contrast.
So the cases themselves are universal, but the grants that we collaborate on is on a single EHR.
What's your other epic question? I mean,
Ever there was a Freudian slip.
That was it.
So from Emily.
Hi, Emily.
Galski,
No,
if I
hi,
pronounced
Emily.
that correctly. Simulated EHR,
Hashtag.
Yeah, hyphen, training feedback loop. Does that lead to design specs for improved real EHRs from the many vendors?
So for the many vendors, I can't tell you. What I can tell you is that based on our data, we've actually redesigned 9 screens for our EHR and created a whole new set of interfaces that we are now going to be rolling out and testing for our own clinical environment. So what we did is we realized that one of the reasons we thought they're scanning back and forth to so many screens is data is organized by content type as opposed to relevance type. Meaning all the laboratory values are together, all the medications are together, all the vital signs are together. Instead, what you would want is for everything related to the heart, labs, vitals, medications all be on one page. Everything related to infections, labs, vitals, medications, culture results, all on one screen. So we've now taken that observation, built 9 new screens. We're almost done. We're in the second level of creation of them now. I mean, we have our first draft, and now we have to go and tweak them a little bit. We're now going to be able to use another simulated case that nobody's worked on yet and do a randomized controlled trial to see, does it improve usability? Does it improve error recognition? And more importantly, what are the unintended consequences to redesigning the screens this way?
Is there a possibility that the sheer volume of data prevents you from designing an optimal screen? You can make it optimal for one problem, but...
I mean, that's a good question, right? I mean, because there's so much data, and some of the data is relevant for some situations, some for not, I think when we look at these high data pathway environments like the ICU, we can make a case for a better subset than we can, for example, in the outpatient setting. We hope that there will be these concentric subsets that you can define that will allow you to define data sets that can be imported for specific scenarios. But I think the problem is immense, that we don't have enough information about how clinicians interact with the interfaces in these environments, how they think and process cognitive information, and how that is rendered actionable in that particular environment. So there's a lot of research that's required in order to make this truly universal.
What I would say is what we need to do going forward is actually be able to have the ability to create customized watch lists for each of our individual patients once you get to learn them.
Right.
So that I could create for each one of my patients in the ICU my top 10 list of things I want to be notified about that are unique to that individual patient. That would be one. The second thing is I think we have to get away from this idea that, and I'm channeling my inner Chuck Kylo for those of you who know Chuck, is over-customization is great, but standardization is still necessary. Meaning that we should be able to customize based on workflow and environment, but standardize across users. So what we need is pediatricians should have their set of data points and sheets that are useful for them. Take out stuff that they never use. But those data presentation screens should be different than an orthopedic surgeon. Keep it focused for them, for what they're doing, so they're not distracted by data that they never use. But what you need to do is standardize it across all the orthopedic surgeons.
So I think another way to kind of put that, if I could add one point to that, is we often think of customization in terms of customization for the clinician. It is a convenience and a feature for clinicians' use. I want you guys to think about customization from a totally different perspective. Think about it as customization from a patient perspective, that the clinicians are able to use the glass cockpit and the standardized interfaces, but it's really the type of machine that you're flying and the people you're flying in that type of machine that determines the customized interface. I think that throws the concept of customization on its head.
So Neil,
So this is really
press the button, buddy.
Oh, sorry. Oh, okay. This is fascinating, and you're really hitting on some very interesting nuances here, because circadian approach is really important in diagnostics, because if you're coming at it from trying to process a large information and hang it onto some sort of preconceived idea or a pattern, that's really where you have to go after lots of stuff. Fixation might be useful in other scenarios. So it's actually, that may have a purpose, a different purpose. And the ICU, you basically set it up as essentially a simulation of sort of continual diagnostics, right? And so this is also gives us some sense that there may be other reasons why there may be adaptations of the EMR that may be very useful for the purposes of fixating on one's. And I think you just kind of touched on that in that last statement. In that there's lots of different uses that people come at this body of data for, and you're going to probably get different results in the eye scans that's driven by that.
My goal is, you're absolutely right, Neil. And when I spoke to some people down at ONC a little while ago, they were saying, well, what can we do to improve the quality of and safety of electronic health records across the United States? They put in meaningful use. Everyone's adopting them. They all know that this is causing problems. What could they do to write it? And my answer to them is what they actually need to do is create a library of 250 to 300 use cases that span the spectrum of new admission, follow-up, inpatient, outpatient, across the spectrum, so that it would not matter. So to answer Elizabeth's question, if she's still actually listening, is what we actually need is so that someone could take my ICU case, if that would be deemed a valid case, one of our ICU cases, and test it at the University of Pittsburgh when they're implementing their new system, so that there's standardization in the testing process as each institution customizes and implements EHRs based on their own needs.
And going back to that question, shouldn't the vendors be doing the performance tests that you're doing here, rather spending the time at thousands of institutions all doing their own customization?
That's a difficult question to answer, because the way that the product is now delivered to the customer is in essence an incomplete product, and there's a significant degree of work that the consumer does in setting up the product the way they want it to. So what you're suggesting, or the hidden suggestion that you're making, is that that EHR vendors deliver a turnkey product rather than something that can be customized. I don't know if the business model allows that at this point, primarily because I think that healthcare organizations may not be interested at this point in buying an absolutely turnkey, can't touch it option. And we know this because that's how the field, that's how the area of business has evolved over time. I think we may end up at some point, maybe by mandate, maybe by other reasons, to force healthcare organizations to all use the same product. But I think in the political and economic and social structure in the United States, it would be an extraordinarily difficult task to mandate a standard interface that the EHR vendor would force on a customer.
And what I will say is this, just to add on to your question, this is the equivalent of testing a new airplane under a simulator in a simulator, but only testing that under normal weather conditions, normal takeoff, normal landing, and a completely full fuel tank. What the vendors, I think, should be doing, I would like for them to be doing, is actually testing the Captain Sully, right? Can you land the airplane on the Hudson River? Maybe there's a problem with the design that you can never do that. The other thing is, and it's not focused on at all in today's talk, but what we're still talking about, aside from what we just mentioned today, simulation is a huge part of education and healthcare, right? Everyone who's done BLS and ACLS, that's simulation, right? Compress on the mannequin, intubate it, do whatever you want. And people do mock codes all the time. We're now working on the cognitive data part. Those two have to be married together. And I can tell you what we are doing is when we actually incorporate the EHR into our real-life simulation training exercises, we uncover even new barriers and problems with using the EHR when you're actually having to do it in real time with a simulated patient, with all the bells and whistles beeping. You're forced to make decisions even quicker, type on the run, and communicate. So here's the last example I'll give before we break up. So we were doing this. We were doing our resuscitations in the ICU. We had a high-fidelity simulation mannequin. We had the EHR incorporated. So we had a test case in there, very simple, just enough. So I had a couple drug allergies and a couple old labs. But what we wanted is that the residents had to be putting in the orders in real time. So instead of saying, give me the antibiotics, they had to type them in. Instead of give me the product, they had to type, just like they would with the real patient. So what did we find? So the antibiotic the resident chose was something called levaquin. All right, levofloxacin. It's a quinolone. Levaquin. All right? So they're typing it in. The resident is talking to the other resident about which antibiotic to type in. They're on one whole side of the room where this guy is right here. They type it in. The nurses are over there by where Joan is, on the other side of the room. They don't hear. Okay? Meanwhile, the patient's blood pressure is dropping down. The nurses over by where Joan is are saying, we need some medication for the blood pressure. We're going to give Levofed, which is a vasopressor. You can see where this is going now, can't you? Well, here's an interesting issue. You can't type in an order for norepinephrine or Levofed until there's a weight in the system, because it's a weight-based med, and they hadn't gotten the weight yet. So now the nurse comes out and says, and I'm acting as the pharmacist, I'm the Confederate, and they say, give me a bag of Levo. Well, I'm the pharmacist. I'm looking in the system, and all I see is an order for Levaquin, because that's the only one that could be validated. So what happened? They hung the antibiotic to titrate the blood pressure, which didn't work so well. Now, again, this is for those listening online, this is a simulated case. It's with a mannequin. No flesh and blood was hurt in this case. It was all plastic damage. But these are the ideas of the type of testing I think actually needs to be done. We have to no longer consider the electronic health record as the paper record with a plug. It has to be considered like any other medical device, whether it's your ultrasound machine, your central line kit, or anything else, and be integrated into our learning objectives. And the first step to doing that is, one, understanding usability of it, and two, is having standardized cases that you could use across the system so you can get replicable results. Because the users and the users are definitely changing. Users have different skill levels. So you at least have to standardize the cases.
So now that Jeff has reminded us so eloquently that the cup is half empty, I'm going to close this down. Thank you very, very much for coming and spending some time to listen to us. Thank you.
Thank you very much. Good job, man.